Thank you, Yasmin. Thanks everyone for being here. So I was going to start with a whole bunch of stats, but I think they've already been very well outlined to us by Yasmin. But we probably already know the stats. That means, 1 in 4 women in Australia have experienced intimate partner violence. 1 in 5 have been sexually assaulted since the age of 15. I'd say these stats are probably a bit higher. This is just what we know. But statistically speaking, that means we probably all know at least one victim survivor, probably many, or we are ourselves a victim survivor. And yet many communities still operate under the belief that this doesn't happen here. I don't really know anyone. All the men in my life are great. So Nick, I might start with you. Given your work supporting over 200 women and girls fleeing domestic violence every night, how do you think we can help people understand the sheer magnitude of the, and proximity of the problem?
Yeah, I mean, if the stats don't do it, I'm not sure what does, because they're pretty compelling. I mean, at WageEc, as you said, every night we have over 200 women and children who are fleeing family and domestic violence, who can't go home because it's not safe for them to go home. And they come in and stay with us. And when they come in, they've got almost nothing, very little most of the time. And they're really needing to get the right support to make some really big decisions in their life around what comes next. And, we know that those children also need the right services to make sure that they get the care and support they need to recover from those experiences. And that's one of the things at WageEc we're really, really passionate about, around making sure that, children are also considered victim survivors in their own right.
Yep. And you mentioned they need the right services and support. Obviously, we're here with a healthcare focus. Healthcare providers are often the first professionals that victims of domestic violence and also sexual violence encounter. Yet distinguishing between accidental injuries and those caused by other people can be quite difficult, especially where an abuser might be putting pressure on victims not to disclose certain information, or the survivor themselves might be putting pressure on themselves. I might just ask the panel openly, how can healthcare professionals distinguish between the accidental and the deliberate injuries? And is there any training you might recommend that people in this room could consider?
So there is specific training that you can do as a healthcare professional and allied health professional that is not for a specialist response. It's a federally funded training that is free to do called DV Alert, and you're certified from it. It's a really good training. I think though what I would take into a room with that is that when you are treating an injury that you suspect to be DV, it isn't any healthcare professional's job to make a moral decision about that injury. It is to treat the patient and provide referral pathways. And I think that sometimes is where we have a misstep in terms of how our justice and health systems interact. But I know Karen can certainly expand on that.
I'm dealing with a matter on the periphery at the moment, with a matter of a woman who was, I would say, murdered by her former partner, partner at the time, former now because she's dead. She was, on the day that she was murdered, he was in custody with police for domestic and family violence crimes. She had reported to police. The police then told him what she had alleged. He was then released with a blood alcohol of 0.8. He then went home and murdered her. She, and I say murdered, that's my term, not necessarily what the court, I think in this matter the court found manslaughter. And she recorded her death. She was assaulted 127 times, including sexually assaulted. She died 2 days later in hospital, and the cause of death was seizure. And she had, with him there, informed the hospital staff that she'd fallen out of bed. Now, one can imagine the scale of injuries that this woman had. And that lack of connectivity between our justice system and our healthcare systems and the referral pathways is still a massive problem. And I think we really, as within a healthcare setting, what can be done? Risk assessments. There are tools, Kat's just referred to the training that can be done, but there are risk assessments. We also know that women at particular points in a relationship are particularly vulnerable. Mm-hmm. And at those points, I think we need to be designing particular interventions and particular support for healthcare workers to make sure that they're able to identify, risk assess, refer and support women and children and their unborn children in the way that they need at that time. So I think that's, and that's just, I've just shared one very graphic example. Stay tuned in the media in the next couple of weeks, you'll read more about it. But unfortunately, I think the perception, to your point, Hannah, is that these are isolated incidents. Mm-hmm. They are not. We've got DV, 1 in 3 women. Sexual assault was 1 in 5. It's now dropped to 1 in 4, particularly for younger women. That trend is going the wrong way with sexual violence. And when you've been a victim survivor of sexual violence, you are more likely to have perpetrators pick you out and prey on you again and again for sexual violence, but also domestic and family violence. So these trends are alarming. They're going the wrong way. The federal government is right to call it a national emergency, but I think our healthcare system, our health insurers need to be getting on board with that national emergency and changing stuff pretty quickly.
Mm-hmm. Speaking to that point though, it doesn't sound like the police were safe. So who should, when we say we need the referral systems, who should healthcare practitioners be referring these people to?
I think it's a really complicated response because we have amazing specialist services like NICS, services like my dear colleague Karen Bevan. We do have these amazing frontline services. The problem is this issue is in every community. It is in every single community in Australia, and it brings me no joy to say that at all. But the reality is we yet haven't grappled with our crisis response volume and then the needs when we have medical crisis that requires an intervention. So we say there needs to be clear referral pathway services to specialised services. I absolutely believe that. Fundamentally, I do. However, I do often grapple in my work with the federal government with, well, okay, so we've now referred a victim who's appeared, had their forensic examination for sexual assault. We've now referred them to a service that says, we'll talk to you in 18 months. And that is the reality. In Queensland, we have 12-year-olds on 18-month sexual violence waiting lists because there are no services. So it's a joint responsibility between federal and state and territory governments in how we actually manage demand and how we manage that load of crisis response, whilst also working in tandem with what Karen said, early intervention pieces, so we stop catastrophic outcomes, particularly for children who have been exposed to violence.
Okay, so let's say we've got someone in hospital and they've been referred on and they have that 18-month waiting period. Mm-hmm. What can the community, anyone in this room, any organisation, what can people do in that 18 months to support that person? Is it the healthcare practitioners who can step up here?
Yeah, I think the majority of referrals that come into us at WAJEC, they do come from the police and the hospitals.
Yeah.
Mm-hmm. So, don't stop referring. I think it is absolutely right that we're completely overwhelmed with demand. Mm-hmm. And, for every room that we have vacant at WAJEC, typically it's 3, 4, 5 families. And our frontline staff have the absolutely impossible task of choosing who is the person who gets that room tonight, and it's something that we should all really care about and all be voting on and, calling for change, because it really can be any one of us. At the same time, I think as a community, we can make sure that we are creating a space where we can offer non-judgmental support and care, believe women. And we know that it takes the average woman leaving 7 times before, you know, that break is made for good. You know, if I think back to when I left, you know, I've lost count of the amount of times, you know, it took me. At WAGEC, we talk about little leaving and big leaving. And, you know, for a lot of us, there's a lot of little leaving, there's a lot of rehearsal that happens before the main event. And as a community, we've got to make sure that we're supporting people through that, not judging them, not pulling away, not saying, oh, if she goes back, that's it, I'm out, you know, I'll never talk to her again. You know, we've got to understand the reasons behind that and make sure that we're not letting people be isolated, because we know one of the biggest risk factors is isolation. And we've really got to stand together as women on this issue.
You go.
I think, just to pick up that point on disengagement, Nick, that another matter I'm working on at the moment, the Aboriginal woman, she sought help 24 times before her and her 8-month-old unborn child were murdered. And he's been convicted for manslaughter, not murder. So, you know, in those 24 times, unfortunately, this is in an 8-month period, 24 times. And unfortunately, there was one of the services had kind of, you know, oh, she's disengaged. And having a trauma-informed response would actually understand that as, well, this shit is bloody hard. Like, I'm sorry, but today I can't engage with that because today I'm trying to hold down my job, or today I'm trying to get the kids off to school, today I've got blah, blah, blah. So how can we, in the meantime, and while there are these service gaps, all of us be doing what we can? And I think that understanding how domestic, family and sexual violence, how does it look, how does it present, how does it show up, and how does trauma show up? And then how can we all make our own services, companies, businesses responsive to that? So, for example, with you know, seeing a gynecologist, I mean, as a victim of sexual violence, that's an incredibly, like, I ain't going there, sister, kind of thing. So how can that be made possible? Going to the dentist with someone putting things in your mouth is incredibly traumatic. How can that process be made to be comfortable and reduce the trauma, so that, you know, going to the optometrist, and I know, I can't see her, but a friend of mine, Michelin, is here somewhere. There she is. You know, how can we, you know, having those things right up close and poof, the, you know, the stuff in your eye and all this stuff, how can we make that less traumatic so that as victim survivors, your stress hormone isn't constantly firing multiple times through the day? How can we make services like that? And that is something I think we can all do. But believing women, we've got to start there. I mean, again, another legal case, Hannah Clark from Queensland was in the press this week, that for 6 weeks, her gut was telling her he was going to kill her for 6 weeks. And she disclosed and disclosed and sought help from police, sought help for 6 weeks. She felt that in her gut. And how do we, as women, as health professionals, as friends and family members, how do we listen to women when they say, in my gut, I know he is going to do something?
It really demands that we challenge our own biases, right? And the fact is, everyone has them. Anyone who has had a glimpse of a moment where they've read a headline and gone, wow, that person was really drunk, or, oh, wow, was she wearing that out? Everyone's had those thoughts. And you have to continuously challenge yourself on them to say, actually, it's not about what occurred to them. And those small acts of challenging bias actually gets to the core of believing women, because everyone's a great guy until they aren't. And actually being confronted with when you have to then challenge that someone you know has perpetrated horrific acts of violence. Most people don't want to work through it because it's too hard, because it is ugly, because it is tough. But the reality is we actually have to change the structure in our society of how we think about violence. We know that from research that, you know, so we have a very engaged audience of women here. We have 4 women on the stage. all who have lived experience. There's a lot of lived experience in the room, and yet our research will tell us that people think that violence is an issue in someone else's community and not something they ever have to deal with.
I think that point about, you know, so I think it was for Women's Agenda actually that I wrote an editorial called "Abusers are some of the nicest people you'll ever meet," because they are.
They are.
And abusers are just as good at grooming allies as they are at grooming victims, and that's how they're enabled to abuse.
Absolutely.
And you just reminded me actually of a story where a really good friend of mine, really wonderful woman, was telling me how she's 50 plus years old, she's senior in her career, and she was groped and followed home after a networking event in her industry where she's well regarded. And the first thought that came into my head was, probably didn't happen. And I trust her and I believed her. I actually believed her, and yet that was still the first thought that came. And to give more context, as you've said, like I've been sexually assaulted on the street in unusual circumstances, like actual rape 3 times and God knows how many indecent assaults, and yet still probably didn't happen. And so that kind of conditioning, like if that's how we kind of respond.
Because Karen's mentioned some case studies that are the pointy end of a crisis, that are horrific.
And people tend to believe them because they are real.
But there's
violence.
there's a visual element there, right? So there's a visual element, there's physical violence, but again, someone asked for help 24 times and we're rejected at every turn. So I think it's also about understanding a continuum of behaviours, as you did when you were talking about big leaving and little leaving. And I really like that because I think it's just so important that people are exposed to this continuum of bad behaviour, and you may not see a physical outcome of that, but their mind, they are isolated, they believe the narrative they've been told about themselves. I mean, we talk about coercive control, but what we also need to talk about, along with the dynamics of coercive control and what it is, we need to talk about how we actually visualise it and think about it ourselves when there's nothing we can see or touch or feel except for someone's mental experience.
Yeah, one of the things that we do at WAGEC is we run domestic violence education, and one of the things we get the group doing really quickly in the sessions is to think about, you know, what are the roles women play in society? What is society telling us about women, and what does society value? And, you know, we start to get the women we're working with thinking about gender equality, because actually a red flag, and one of the first red flags way before physical violence happens, is gender inequality. So if we know not all gender inequality results in domestic violence, but we believe at WAGEC that all domestic violence begins with gender inequality. So that's something that we can all do something about all the time, you know. Our boys are equal to our girls are equal to our boys. How do we correct that when we see that not happening in lots of small ways every day right across our community? Because, you know, the more likely someone is to not think of women as equal, the more chance there is that they'll be able to dehumanise you know, their wife or their partner, their sister, their mother. And sadly, you know, we're seeing domestic violence not only with intimate partners but with sons becoming more of an issue. And, you know, it's horrifying.
Yeah, and that's a great point, the gender inequality. How does the intersection of, say, race, LGBTQI, you know, ability, how does that impact?
I mean, I think, you know, Hannah, when you were talking before about believing women and the stereotypes that can be put on different types of women, gender binary people, trans women, children, that some women are more believable than others. The woman in the suit who's the lawyer, technically, I don't think many people believe me, but technically our society, thanks Kath, technically our society says this type of person is believable and credible, whereas the Aboriginal woman who's experiencing homelessness and is using alcohol as a way to escape the trauma is someone who is not believable in our society. And I think, we can all, children, let's look at the disbelief of children in our society. And that's something we can all challenge within ourselves, and also institutionally, I think, challenge. And to pick up, kind of circle back to the healthcare system, making sure that when you're hearing these accounts, you document them properly, no matter what setting you're in, whether it's at the optometrist, whether it's at the GP, whether it's at the gynecologist, that those things are being documented, because the amount of, that is one of the points of either disclosure or where someone is particularly attuned to it, that later down the track, you don't know when those notes are going to be needed. So really making sure, and I appreciate it's time consuming, maybe AI can solve that, but how do we make sure those records are there for later, because they will be needed, and victim survivors rely on professionals to take those records and store that truth for them.
It's storing the truth, isn't it? I think that's the really important thing, that not what you perceive events to be, but the events as they actually occurred. And I think sometimes we've heard of cases through our membership where people have had a perception when they've been treating someone, and that perception made the notes, and that's not actually factually what occurred.
Well, thank you for that, Seg, because that's actually a topic that we really, we talked about behind the scenes as we were discussing this. The intersection of the healthcare system and other systems, so the legal system in particular, is a really critical one. So as we've said, clinical notes on injuries and patient interactions can become crucial in legal proceedings. I shared a situation that happened to me that I think is important for us to talk about here. I was taken to a hospital after overdosing on sleeping pills. It was a very long abuse episode. I just wanted it to end. My abuser took me, and the nurses recognised domestic violence, took him away to do paperwork, and quickly told me I'd be receiving a call from a refuge. Don't answer if he's around, etc. They told me it was domestic violence. I didn't know. I was just there trying to stay alive. Fast forward 6 years, I will be testifying against this man. I contacted the hospital, asked for records of that day. On writing, they said, she said it was domestic violence. And I did not. I was, I was just too traumatised to make any sense of anything. I guess my question is, what the fuck? What happened? Why, and what could be done differently?
What the actual fuck?
What the actual fuck is my question.
Yeah,
It definitely, I think that awareness raising within the profession around how the importance of note taking and accurate note taking, but also trauma informed, like actually understanding what violence looks like and how trauma presents is really critical to then be able to describe it properly. But also I think, and shout out to Medibank Private, who I know is a sponsor, there's a real piece here for insurance companies to look at, because at the moment what's happening with insurance is that if you're someone who, and we know that women are more likely to seek mental health support, we also know that women are more likely to need mental health support given the array of trauma and violence that we experience. So not our fault, right? Not our fault that we are injured, not our fault that we need mental health, and yay for us that we're seeking it. However, insurance companies are then penalising victim survivors and knocking them off income protection, TPD, insurance, and workers' comp, employment law is actually my job, because of a pre-existing psych injury, because you've been a victim of child sexual assault or you've been a victim of domestic violence, so you are more predisposed to a mental health injury. So off you go. You're not covered. Exclusion. You're not covered for mental health.
Yep.
And that is disgusting.
Agreed.
And something that I hope someone here from Medibank Private, if you're brave enough to put your hand up, I would love to have the conversation, because, yay, And so I'm quite aware, like I've been doing a lot of lobbying on this issue and the work of actuaries and blah, 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 blah. But it's actually a penalty for victim survivors and very real cases that victim survivors are having to go through.
It's a very, very painful discussion to listen to, and I appreciate that you're all, embracing that this is an area where we can all have safe space and talk to it. So thank you for that, first of all. Private health insurance is community risk rated. You're not excluded from mental health cover at all.
That's not true.
TPD, critical illness
Yeah.
injury is risk rated, and you can have exclusions and loadings put on your cover. So completely different. We're community risk rated. There may be a small wait period, but we cover for the community everything. We don't exclude people from mental health that have a predisposition or an existing mental health condition.
That's lovely to hear, but my clients would beg to differ, not necessarily with Medibank Private for all the cases, but my clients would beg to differ with the insurance industry. So there's definitely work I think that all of us can do, and actually leaning into it and going, oh, here's an unintended consequence. Here's an unintended consequence of an orthodontist running scans on a woman's mouth that may or may not be necessary. Here's an unintended consequence of how a gynaecologist goes about an examination. So I think there's an opportunity not to be defensive, but to actually lean in and go, how can we make sure that the culture of victim blaming, the culture of not believing victim survivors about their experiences, how do we dismantle that as a society?
But is there a tension here? Because we need the medical notes. I need them to go in court.
That's right.
But I got an exclusion.
That's right.
Quarry insurance because of
That's
my
right.
treatment. So I now go to a psychologist, whoever, and say, please don't write any of this down.
And I've
Then
got
I can't use it in
clients
court.
who won't access the 10, or it used to be 20, now 10 again, free mental health, because it'll come up on their doctor's
And they'll be
records. And if
crazy.
they get in a family court proceeding, they know their ex-partner will subpoena.
Yeah.
And they'll see it, and then it'll be, well, what's going on in that household? Yeah. So it is an issue that would be really great to have increased look at in the profession, but it is, I think, help seeking is good, right? So we don't want to put barriers in front of that. How can we work together to allow more help seeking, not have barriers, and to encourage women so that we're not going, oh shit, maybe I shouldn't, put it on the record because maybe it'll have these unintended consequences.
But not necessarily expecting women to walk in saying, oh, hi, I'm a victim survivor of domestic violence either.
Yes.
Because, if I think back to when I was a young person, I knew that what was happening in my house was all kinds of stuffed up. I knew I didn't feel safe. I knew, that I was willing to jump in front of my mum and try and protect her and protect my siblings. I knew all of that, but I didn't identify as someone who was a victim survivor of domestic violence at all. And I don't think most people in my community did. I grew up in Blacktown in Western Sydney, and I would say that the vast majority of people I grew up with didn't think of their household experiencing domestic violence because our women fought back. They weren't women who were cowering in a corner, scared and calling the police. They were women who were, throwing the saucepan at his head and trying to get away and giving him what for. And so for me as a young person, I was a little bit confused, like, oh, my mum doesn't act like those victims on TV, So there's still a lot for us to do to educate people about actually what is domestic violence in our community. And, we're not just talking about physical violence as well. And I think, as health services and services generally, we've got a real role to play in that. It's not always about labelling it too quickly. It's about leading with care and support and reaching out to people to hear from them about what it is they need and building that trauma-informed, supportive relationship so you know, we can get to know each other and in time really understand what's going on.
Because there are no perfect victims. There are no perfect victims, there are just victims. And every victim is deserving of support, care and empathy. And unfortunately, we live in a society that likes to grade that based on. And so when we talk about that pointy end of crisis, as you said, people believe that. Well, they believe it because there's a catastrophic outcome. There's something tangible that they can touch onto. And I think that's why when we think about holistically our community attitudes that sort of infiltrate every aspect of our life. We have people who want to seek mental health. We encourage that in one aspect. However, we know that that could cause a problem within the family court. That system then needs to speak to the other system and make changes. And I think that these biases that we've touched on already, they run so deep in our systems and in ourselves. And that for me is the major reflection piece when we talk about work, health systems. How are we examining the bias?
And I feel like we could sit here for another 3 hours, and we've only just sort of, touched on the very start of it. I'm going to ask one final question, and I'd like each of you to answer, and it's a double-barreled question. For the people in the audience, what's one change you'd want to see to the medical system if they're a healthcare practitioner, and what's one change or thing that they can do now as just a person in a community who probably knows someone who's a victim survivor? So a professional and a sort of personal change that can be done.
Yeah, for me it's non-judgmental support and not letting anyone be isolated, you know, and just making sure that you're standing by the women in your lives. If it is, you know, in a kind of family or friendship context, you know, it's really easy for people to pull away because they find themselves, you know, worried about a person. But actually standing by that person and staying with them, not letting them be isolated, because isolation's a tactic of perpetration.
Mm-hmm. Absolutely. Thank you.
I think you know we've covered it in the sense that it's about believing people, and I think again it's easier to turn away and be frustrated when you can't problem solve for another person, when you can't say you have to leave now and the person doesn't leave. It is actually the easier choice to walk away. The harder choice is to sit in the discomfort with that person, because if you feel uncomfortable, imagine how they feel. And I think that, for me, is what we all need to become better at in order to start moving those community attitudes.
I think creating the space for disclosure and conversation and support to kind of come in. So, you know, make it standard practice that you see a woman, a child on their own. Just make it standard so that you're giving space for the conversation, and you're giving your girlfriends space for the conversation. The husband or the partner doesn't always need to be there, does he? Surely, you know, how do we actively create those spaces that disclosure, conversation and support can happen in? And sometimes that involves booting the bloke out a little bit. And I say bloke, you know, we know that it's you know, 95%, 98% of perpetrators are men, but not always. So, you know, just have that time alone, have that quiet, you know, time where people can really get into and don't always be on the clock. You know, these conversations take time. I think this is the one thing that Aboriginal communities do well. Things take the time they take. Mm-hmm. They take the time they take. And it may not, as Nick said, you don't just come at it off the bat. It might not be until 20 minutes into a conversation that something, you know, there's a little inkling or a little gap. So, yeah, these things take time, and you've got to create the space.
Yeah, and I think what you've all said can be applied in both the personal and the professional setting, so that's really, really valuable. So thank you.
Thank you. Thank you.